This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Thank you so much for being here for Fellows Conference presented today by Dr. Dolphurs Hayes. Dolphurs is a graduate of Morehouse School of Medicine. He did his residency at MGH, and we were really fortunate to have him come join us here at Emory. He is a second-year fellow interested in sports cardiology, and today he's going to be talking to us about the use of VO2 max. It's all you, Dolphurs.
All right. Well, hello, everyone. Good morning. I think I probably met quite a bit of everybody at this point in time. Again, you're a second-year fellow and still interested in sports cardiology for now, and also some imaging component as well. So last year for the lecture that I did, it was mainly just sports cardiology and how we can view it in a generalist broad view. But this year I tried to take it a step deeper and go into something, the VO2 max, that hidden vital sign that everybody don't talk about enough. Because there's been a lot of data that's been published about it and why it has like mortality benefits. But again, you never hear it kind of come up on rounds besides in the CCU when we talk about VO2, when we were talking about the Fick equation. So today, I hope everybody able to take something from it and be able to put this into your clinical practice. So first off, let's go through the objectives of today. So I'll first define what is VO2 max for the people that are scratching their head now, like, what is this? And we'll kind of go through the physiologic determinants of it, like what caused it to make up to be that way. And next, we'll go through and recognize the clinical significance of VO2 max as a predictor of health and mortality. And lastly, we'll apply the VO2 max data that we will learn today and see how can we put this inside of our preventative practice and also clinical practice, such as like valvular disease, heart failure. So it's a wide array of things that we can do. So first off, let's go straight into what is VO2 max. So just to sum it up, if I had to summarize it, I would say just a maximum amount of oxygen your body can use whenever you're working out intensely. So when you're going on that long run and breathing hard, it's a point in when your body just stops using oxygen and you go straight into an anaerobic area. And that point where it transitions and plateau lets you know your cardiovascular fitness. And the beautiful part about the VO2 max, why it's such an important marker of health, it interacts between your heart, lungs, and your muscles. So you're getting pretty much 3 pieces of data all in just one value. Because if your lungs are not absorbing oxygen properly, that's going to throw off the equation. If your heart isn't pumping the blood out efficiently, that's going to throw off the equation. And lastly, if your muscles aren't extracting any oxygen out for whatever reason, if you have some glycogen storage disease like we learned from med school, or something with your mitochondria, is also going to throw those numbers off. And we'll be able to walk through these step by step so you will feel confident, even if somebody shows you some CPET data, that you'll be able to interpret this. So I always like to give background on whenever I talk about anything, because everything starts somewhere and it has some evolution to it. So it goes all the way back to the 1870s with Adolf Fick. And I think all of us have heard the Fick point at this point. So he's the originator of the Fick principle. So during the 1870s, he noticed that as a person starts to work harder, whether you're on a treadmill, walking, you're going to use more and more oxygen. But at that point in time, he was thinking it was more of a linear relationship. So as you work harder, you use more oxygen. So he didn't really get the concept yet of it plateaus out eventually. Eventually, you just stop using your oxygen and switch over to anaerobic. So we're going to fast forward 50 years now. And now we're going to start talking about Archibald Hill and Hartley Lumpton. So these were physiologists, and they took it a little bit step further. So at this top right here, what I'm circling with my mouse, we have this apparatus, these big bags here, they call the Douglas bags. So what they did was they put people on these treadmill ergometers. So they was able to grade their exercise, had them hooked up to a mouthpiece, kind of similar to our metabolic carts we have now. And they hooked up to one of these big bags. And it was very clever, even though it took a lot of time. So each one of those bags covered about, well, it took in about 200 liters of air. And what they did for each grade of the exercise, since we use the Bruce protocol for most of our workouts now. So let's say you would just start in stage 1 of the Bruce protocol. After you finish that stage, whether it took you 60 seconds, they would have to change out each bag. They would get the bag and then go analyze the oxygen and CO2 content. and they had to handwrite this out, which was brutal if you look at it. So for each person that they did, it probably took them 7, 8 hours just to analyze all the data to give this person any information. And fast forward now 20, 30 more years, now the Douglas bat became more of a gold standard. So they started talking about that process in the 20s, but then now the Douglas bats were pretty much all the way on the scene now. Everybody was using them. But the key thing that Hill and Lumpton noticed when they were analyzing the oxygen data and CO2, they realized as people were working out on these treadmills and the cycles, their oxygen levels just plateaued out. They just stopped. Even though the person was still working hard on the treadmill, and it was kind of confusing to them, like, how are they still having energy? And that's when VO2 plateau, or VO2 max is what we call it today. That when it was birthed in the 1920s. And that's when they started thinking of, oh, you go through glycolysis once you work out for a long period of time. And that's that transition, your anaerobic threshold. And we can measure people cardiovascular fitness. So now we get all the way to the 1980s. And this is the time with the metabolic carts. And that's the picture that I have depicted here at the bottom. This is what we're using today. And of course, it completely shatters what they did back then with the Douglas bags. Because now you can get instant data. So what took them 8 hours now could be done in 20 seconds for us. We get in quick feedback time on all of the information that we want. And now in the 2000s, we even took it a step further. Now we have this AI-driven technology. So everybody that's watching this right now, you have on an Apple Watch, you wear a Garmin watch, you have a VO2 max already calculated for you in your phone. And I'll show you by the end of the lecture how you can go and check that and see where's your fitness level at baseline. And I'll also let you know how they actually do this calculations in an indirect method. So now let's go on to the historical study of why VO2 max became so important. Because of course we can always say, oh, that sounds nice, but what does it mean in clinical data? So it was a study done, it was called ACLS, the Aerobic Center Longitudinal Study by Dr. Blair, and it was published in JAMA back in 1989. So the study design, it was out of Dallas, Texas at the Cooper Institute. So Dr. Kenneth Cooper, he was an Air Force physician, and he was very big on preventative care. So in 1970, he decided to open up this Cooper Institute at that time. And he mainly seen, it was kind of like executive physical. So most of the people that he saw were very healthy. These were upper middle class people. Everybody didn't really have any like major issues. So he wasn't seeing heart failure patients. So this wide age range you see from 20 to 80 years old, he had all these people in his practice. So they decided they wanted to kind of study this VO2 max and see what does it mean. So they took about 13,000 men and 3,000 women from the patient panel that agreed to the study. They followed them on mean about 8 years. And what they did for the method of the study, they wanted to put them on a treadmill. So they did treadmill testing. So instead of doing the Bruce protocol, which we know today, they did the Balka method. So the Balka protocol is a little bit different. It's much simpler. And the reason it was simpler because they had almost 16,000 people that had to use in this study. So they needed a method that was consistent for everybody. So with this protocol, what you'll do, you'll set the treadmill at 3.3 miles per hour. And every minute you will increase the incline by 1%. And you did this every minute until the person burnt out from fatigue. So it could have been from chest pain or anything of that nature, you was excluded out of the study. But if it was strictly just from fatigue, they was able to enroll your data. And what they did was they let everybody go. So they got data from all other people, 16,000. Then they put them in quartile ranges. So people that was in the top 20th percentile, you would consider high quartile. You was in the high VO2 range. If you were in the middle, of course, you're moderate. And in the bottom percentile, 20th percentile, you were considered low fitness levels. So of course they had to validate this. You just can't go and say, oh, you was on the treadmill for 12 minutes. You have high fitness or you have a high VO2. So he had to validate it. So he put these people on their form of the CPET with the Douglas bags and they correlated. And what they found is the people that was in the high fitness category actually did have high VO2 maxes. Same thing, if people was in the low percentile actually did. So it had a 0.9. That's why I included this 0.9 correlation. So again, it was kind of validating that the results that they got were real. The outcomes of the study, they looked at all-cause mortality and secondary cardiovascular and cancer mortality. And the results were pretty profound. So from the primary outcome, it was almost a 3.4 higher mortality risk if you were in the low fitness level when you compared yourself to the higher fitness group. And you can see the p-values and confidence interval there. But it was a significant part of this. They adjusted for age, smoking, blood pressure, cholesterol, diabetes, even weight. And what they found is they still had a higher, when you had a higher mortality rate in that low fitness group, despite if you smoked a cigarette every day. So that was the big thing from that study, from the primary outcome. And looking at the secondary outcome, it seemed that it was mainly driven by the cardiovascular mortality. It did the cancer, but it was like borderline significant. So I wouldn't put that as a piece that kind of drove it to the next level. But the cardiovascular mortality, it was the big thing that drove them to say, hey, this is something significant that we should think about. So the clinical impact of this was the first study. In the first study that showed that having low cardiorespiratory fitness was just as potent as smoking a cigarette or having diabetes or being overweight. And the reason why of being that sixth vital sign of being, like I said, so important in somebody's integral health. So very big landmark study that I was able to go back and research, and I think it was pretty good data. So I named this slide the tale of two 55-year-olds because I like to give you all a visual picture of what we're speaking about. So I have two patients, patient A, patient B, and you all going to see something very quick, but they're very similar to each other. So it's a person, patient A, he's a 55-year-old male, African-American, non-smoker, BMI, so you're right at the cusp of stage 1 obesity at 29, stage 1 hypertension, cholesterol is a little elevated, also that LDL, currently not on any medications. He's a work-from-home software engineer, but doesn't really exercise as much. Kind of lives a sedentary lifestyle. So based off of that, his ASCVD risk came back at 7.8. So he falls in that intermediate zone. Patient B, same exact risk profile, as you can see, but he's a high school principal. So he's walking up and down the hallways constantly throughout the day, runs about 3 times a week. So he goes and jogs about 15, 20 minutes, not high intensity. So you can see his ASCVD score is the exact same as the other patient. But now we're gonna do some CPET testing for these people to see can we differentiate even further. And you see for patient A, we did a CPET and the VO2 max came at 22. We'll go through normal values of what this means, but this will be low, below average for somebody 55 years old and a male. And the same test was given to patient B, and they're at 42 mils per kid per minute, which is well above average, especially for a 55-year-old. So using this data, if you were the cardiologist or internist, whoever were taking care of them, you could kind of use this to enhance or expand this ASCVD risk. So you know this person already is in the intermediate zone, but based off the studies that we didn't show the mortality rate of people with low fitness, this could be now bumped all the way to the high category. So you would be definitely more aggressive with this patient on getting cholesterol under control, treating the hypertension, getting his weight down, get him on a good exercise regimen so that you can kind of turn things around. And even though this person here has a high fitness as well, but you would do the similar things, but you will feel a little bit more confident in adding that extra data for this patient. And another big part, I don't know if you all have experienced it yet, but Apple Watch sometimes alert people. If you wear the Apple Watch for long enough, it will tell you like, hey, your VO2 max is low. You're at a high cardiovascular risk. So you will start to get patients, if you already have it, coming into your office saying, hey, doc, what does this mean and what can we do about it? So it is becoming more of a thing indirectly, just given through the technology. So let's now talk about the Fick principle. So the equation was rearranged so that we could solve for VO2. So this is how it will look. So all in all, I tried to draw this out so you all can see it pretty clearly. But it's cardiac output, which we know is heart rate times stroke volume. Looking at the arterial O2 sat, which is mainly just our lungs, and our venous O2 sat. So that's after our muscles go and extract as much oxygen as it can from it. So when you look at this, you can already kind of see things that will throw these numbers off and where you can have areas of problem. So someone has health ref, stroke volume is decreased. That's going to drive down their VO2. Same thing, somebody have any lung issues, interstitial lung disease, COPD, severe asthma, anything with diffusion capacity of oxygen getting absorbed inside of the blood is going to drive down your CO2 because this is a gradient. And lastly, I said, which is more rare if you had any type of mitochondrial disease where you're not able to extract oxygen, or in most cases, which is more common, you're just not in shape. So you don't have a lot of capillary density inside of your muscles. You don't have a lot of mitochondria in there extracting oxygen. So that gradient can get low. So by looking at this, we're able to get a lot of data on what this would mean for our patients. And we usually look at the Fick equation, as I mentioned earlier, from like a heart failure standpoint. When you have people inside of the CCU that's in shock when we're trying to solve for cardiac output. And Dr. Burke gave us a lecture a couple of months ago about like the VO2. You know, in the numerator, we just kind of give a surrogate for VO2. We usually do 125 versus the person's BSA. But as you can see, this can get much deeper. It can be inaccurate in different ways because when they created that constant of 125, of course, it was done on very healthy individuals back then. Racially, it wasn't all the way diverse, so a lot of nuances can be in it. But by getting these exact indirect methods, we'll be able to have accurate results on what we're doing for our patients. So now looking into some of the indirect measurements for it. So this is kind of how Apple and Garmin, all these watches and things, how they predict what your VO2 max is. So say we have two people, person A, person B, both 40 years old, and they're gonna run us 1 mile. And in this case, both gonna run 1 mile in 10 minutes. But the key is, because you see people post all the way on their social media, oh, I just ran for this amount of time, I ran this distance, but they never posted heart rate. And the heart rate is actually the most important piece because that's how you're able to calculate the person's fitness. So you can see for person A here, even though they ran in 10 minutes, their heart rate was 170 beats per minute on average throughout the whole run, which represents about 94% of their max heart rate when you do 220 minus 40. And this, of course, would translate to a lower VO2, meaning that you were working pretty much in the anaerobic zone your whole time. So your VO2 max plateaued early on in your run. And this is what this person would look like. Probably what I would look like after doing a lot of inpatient months and not being able to exercise as much. So you would be burnt out pretty quickly when you start to build up all that lactic acid in your legs. Versus person B, run that same distance in 10 minutes, but the average heart rate of this person is 125 beats per minute, which is only 69% of the max heart rate. And this would translate over to a higher VO2 max. And of course, this person would translate over to this guy here. I don't know if you all are familiar with him, two-time marathon Olympian, the Kenyan, Kipchoge. So he probably had one of the highest VO2 max we actually measured it for a human, just giving how well conditioned he is, how his heart, lungs, and muscles all interact with each other. But these are the heart rate trends. So what Apple would do, it will look and see that this person has this high heart rate, even though they ran at 10 minutes, and it'll input this inside of your age and show you, hey, this is where you fall at with your age group. You're in the low percentile. Same thing over here. So this is that indirect way of how you can kind of measure this, and also how you can give exercise prescriptions to some of your patients, which we'll talk about. So what determines VO2 max? Which is a very important question and which you'll be asked inside of your office. So I included Travis Hunter here. This was the Heisman Trophy winner from last year in college football. And he was a little bit different from typical football players. So football players usually play on one side of the ball. You usually play offense or defense. So you have some time to rest in between plays. What made him unique, he played both sides of the ball. So he was actually on the field about 95% of the game, which was unreal for people. And he was still functioning at a high level, meaning his condition has to be superb. And you look at this first bullet point I have up here. So genetics make up about 50% of your VO2 max. So these are these people that could come around, they don't work out for about a year, but can go and run a half marathon and finish it. Because of the genetic things that can happen on the back end just from what you inherited from your parents. But the key part about this and what patients want to ask you about is how can I change it? And it can be changed. So about 25% of this, you can increase your VO2 max by 25%. up to 30% for some people, just by doing like a simple exercise regimen, simply called zone 2 training, which we'll talk about at the end of my presentation. So now let's talk about some of the things that would change your VO2 max. So unfortunately, as we age, and we hit the age of 30 years old, so most of the people, fellows, we're already at that point, and if you're not there, you're coming soon. So every year after the age of 30, you lose about 1% of your VO2 max. So as we'll talk about the normal levels, you will see it differs from each age group. It's lower and lower. So the best thing you can do with training is kind of slowing that slope. So you just kind of plateauing it out so it doesn't fall as quickly. The sex, so your gender definitely plays a big role into your VO2 max. So males have larger stroke volumes, cardiac output. So going back to that equation, cardiac output is at the top. So you have a higher cardiac output, your VO2 max is going to be larger. So when you compare men and women at the same age group, the men are always going to be higher there. And if you have any baseline comorbidities, heart failure, going to throw off your VO2 max, COPD, any metabolic conditions, as I kind of already spoke about throughout the presentation. So now the normal range VO2. So you can kind of see between women and men. So for the fellows here, most of us fall within this range here. So you can get an idea of what normal would look like. So most of the people walking around fall right in the average category. If you fall into this fair, you go into your 20s, that's when if you wear an Apple Watch or any type of watch that tracks it, you will get an alert to let them know that you're in a lower fitness level, and you should probably you'll be able to see exactly that, hey, something needs to be done from a cardiovascular standpoint to improve this. And those people that are in the Olympics and run marathons, we have a few people I think that have ran a marathon in the program. You will find that their VO2 is in the 40s, 50s, and sometimes it even jump up to the 60s. So again, a good marker, and you can see the difference between men and women. And I'm sorry, I wasn't able to get any data for 70, 80-year-olds. So sorry, Dr. Thames, Dr. Clemens, I couldn't get that piece for you, but I'll look for it. So the measurement modality, so the gold standard for getting any VO2 max would be a CPET, which we kind of talked about earlier in the presentation. So that's typically done on a treadmill or your cycle ergometer, or it could be done through these indirect methods. As I already mentioned, your Apple Watch. So this is what the data will look like on your iPhone for people that do have iPhones. If you go into your fitness app and you type in VO2, this is going to pop up and let you know over the last, since you've been having that watch, it will show you your trends to see how it changed. So it's important information. And on the Garmin watches, it will actually tell you directly on it. You can see exactly. So this person would be, of course, a very well in shape person. So now let's go into some of the science and what does it mean in the lab when you're doing a CPET. So what I have over to the left here, we're going to be looking at how you actually get your VO2 max, that plateau. And so the x-axis here is going to be your workload. It's going to be expressed in watts. And then, of course, your y-axis is your VO2, your oxygen consumption. So as you can see, it's very linear at first. As you increase your workload, so you're running faster and faster on the treadmill, your body just using oxygen. And that's primarily because you're in aerobic territory. And this is what, when Fick created the principle, this is what he's seen early on, that people were using oxygen, even at baseline, as they increased their fitness. But then when you look into Hill and Lumpton, they notice right here, it plateaued out. And that's the part where you're now going to reach your anaerobic threshold. So that yellow line here, when it goes to the plateau, that's when you're switching from aerobic to now glycolysis. So now you're making more lactate. Your CO2 levels start to rise. Once your CO2 level starts to rise, that's when you're going to start breathing harder. And despite this person increasing their workload, you can see that O2 consumption stays the exact same. And that's that piece of the factor that where they were able to observe as well. So when people are working out and they may be taking a jog and maybe running too fast, when your heart rate is about 90% of your max heart rate, you're here. So you're really not training your aerobic thresholds. You're more so just running, just burning yourself out. You're going too fast. So this is why some people, when they're trying to get back in shape and they go and get a CPET, they're able to determine this level that's too much for them right now. So you can give them exercise prescriptions of, okay, you need to be in this watt level for now. We want you to train in this and do this for a certain amount of time a week so that you can kind of get this VO2 max up. And now this this graph you have over to the right is now looking at VO2 on your x-axis, now VCO2. And VCO2 is how much carbon dioxide you're expelling every time that you breathe. And again, you can note your anaerobic threshold here. So as your VO2 max, you're using more and more oxygen, just like we did in the other graph. Eventually, that slope is going to change and it's going to rise. That rise, where now you're going to start producing more CO2 for every VO2, is going to be another marker of your anaerobic threshold. And the reason for that, remember I told you, once you reach this level, your carbon dioxide levels and lactate levels are going to rise. And your body's mechanism now, you're going to breathe harder, but that CO2 content, how much you're exhaling, is going to skyrocket. So they use this during the CPET data to verify this. So you can see the VO2 max in the workload, but then you'll be able to kind of confirm like, oh, that was that person's anaerobic threshold, because now look at their CO2 levels. They skyrocketed once they got to this point. And one last data point that you can get from this is the respiratory exchange ratio. So this here is similar to on the Bruce protocol. We want to get that ideal heart rate at least 85% to show that they gave good effort. This is another indirect way that you can do it on the CPET. So they're going to look at this ratio here, the VCO2 over VO2. So of course, once you reach a level where your CO2 level is going to exceed your O2, meaning you're in that anaerobic threshold, that's going to give you a ratio at least above 1.1. So if a person does CPET and it only gets to 0.9, you know they didn't reach that threshold yet. They could have trained a little bit harder and went a little bit further on that. So if you can confirm this, that they at least hit 1.3, 1.4, and seen this plateau, you can confidently say this is their true VO2 max. And lastly, looking at graphs here with CPET, I was able to find this one. This one is your VE to VCO2 slope. So VE means your minute ventilation. How fast are you breathing over the course of a minute versus your CO2 production, same thing that we were just talking about. So in a normal person, this slope is about 20, 30, and it has no units to it because everything is like liters, so it cancels each other out. So this is a normal slope for a person. As they produce more CO2 in the anaerobic zone, your body naturally is going to breathe faster to get it off. So that's why when you're running, you start to breathe a lot faster as you get more and more intense in the run. And that's just your body naturally trying to get rid of the CO2. But when you go into this high slope region, this is when it's more indicative of some type of ventilatory inefficiency. So this could be heart failure, pulmonary hypertension. And it's actually been studied when people have high slopes above 40, you have worse prognosis in heart failure, pulmonary hypertension. So this is why this graph is very important when you do CPET data. And some of the pulmonologists and cardiologists on your heart failure people, they will look at this to analyze a person's risk factors and even start to think about transplant candidacy. So now we'll get into some of the utility in cardiology. So we'll talk about basically three ones. We kind of hit on some of the prevention already, but we'll talk about how do heart failure attendants use this in their everyday practice. In a valvular heart disease world, how could you use VO2 max to help you out? And again, we'll do another case on prevention and how can we use it in the preventative space. So from a heart failure standpoint, I told you it's very prognostic thing that they do. They're looking for that peak VO2, which is the equivalent to the VO2 max. And they use something called a Weber-Janicki classification of how they kind of group these people. And the main thing they're doing this for is to see, have you got to a point where your cardiac output is not going to give you any more? And we're at the end stage and we should talk about transplant. So they base this off the heart and lung transplant guidelines. So with a person in class A, you're usually above a VO2 max of above 20. At that point, you're still in a low cardiovascular fitness range, but you're making an adequate amount that is okay. They're not talking about a transplant yet. The big area of concern when you get into a state with class C and D. So when you get into the teens, so that 10 to 15, even getting like closer to 17, or definitely when you're below 10, is an area where now you're in a high risk category. So the guidelines currently say if you're doing a VO2 max and you're below 12 on a beta blocker, that's a transplant candidacy. You do have the area for that, but if you're on a beta, without a beta blocker, it kind of goes up a little bit. And this goes back to this equation that I put here of how this would affect your VO2. And the main issue is the cardiac output. So these individuals, stroke volume is probably severely reduced. The LV outflow tract VTI, if you measured it on their echo, would probably be low, probably 9, 10. They're not getting much stroke volume out. So therefore, it's going to translate to a low VO2. So even though their lungs can be working amazing, their muscle can be extracting oxygen normal. If that cardiac output is messed up in any type of way, it lets you know you're not going to improve this no matter what you do. So giving this person a new heart will actually be able to improve their outcomes. So next, looking at a valvular disease scenario. So I'll go through two for the interest of time. So first, we'll talk about mitral regurgitation. So say we have a 55-year-old woman with moderate to severe MR, which we do see a lot called on our echoes, and a normal EF. We'll say EF is above 65%. And she's only reporting a little mild fatigue, still able to do her day-to-day activities, but lives a mainly sedentary lifestyle. So she's not going on a jog, can't really get like good data in that. She kind of just roams around the house and do small tasks there. So if you put this person on, did a CPET test, what this will be able to tell you, you can look at the predicted VO2 max. So your predictor would be just as 220 minus your age and kind of get your numbers from there. And a person with a VO2 max of less than 80%, or definitely below 20, which we know is a severe range, it can be predicted that this person, before they even start develop LV dysfunction, because that's when you should be recommended for any type of valvular intervention, you'll be able to detect this early before the EF actually declines. Because what happens with mitral regurgitation, people can go and develop AFib because you're pushing all this blood back into your left atrium. And eventually, because of that poor coordination with backflow, you start to develop this LV dysfunction. So this usually is a later consequence. But if you're able to detect this early with a CPET test, you may be able to get this person over to see the surgical colleagues on the earlier side before they get to that point where the EF drops below 55. And now you're in the range of, okay, you're very symptomatic. We could have caught it earlier on. So while this is not in the guidelines just yet, it could be an indication of something we could start thinking about. If you're in that space of kind of on the boat of is moderate to severe, is it gonna fix itself or not? It could push you either one way or the other based on those results. And going back to that minute ventilation versus your VO2, that slope that you're seeing, can also give you some information about this. Because if a person is just deconditioned, that slope would be normal. But if they were having hemodynamic limitations, so their stroke volume going in the wrong direction, it'll let you know that this is abnormal and their VO2 max is low. This is something that you probably should look into very closely. And I'll put this equation here again so you can see the problem here. So the problem in mitral regurgitation that would drive down your VO2 is your stroke volume going in the wrong direction. So it's not necessarily your stroke volume is low from a squeeze standpoint, is that most of your stroke volume is now going into your left atrium instead of going out your aorta, perfusing your organs. And now we'll look at aortic stenosis, the one we probably see a lot. So we got a 71-year-old male, history of severe AS by echo. So he has all the criteria, the valve area, mean gradient, velocities, and have a preserved EF at 55. But he says, Doc, I have no symptoms. I'm completely fine. So you would classify this gentleman in the asymptomatic severe AS range. So you wouldn't go and operate immediately at that point, but I know some data is starting to emerge in that area. So right now it is a class 2 indication. You could exercise these patients. So right now you could just do regular exercise tests and test for any symptoms. So if they develop chest pain, lightheadedness, or a syncopal episode, that should push you that, hey, you need to do something about this valve now. So even though they're not symptomatic, they're not symptomatic because they're not moving around. But if you can add this extra data with the CPET, not only will you be able to know their exercise capacity with them moving from a symptom standpoint, objectively, now you'll be able to get this data to know that, hey, you're feeling bad, but also your VO2 max is less than 20. It's like it's 65% predicted. So we're going to get you over to get this valve fixed at this point. So another thing that you could do in your preventive stage, or it's not preventive at this point, they already have severe AS, but something that you can do and put in your back pocket to get these people revert over on a sooner side to get something done. So now we can pivot over to preventative cardiology. So in this world, similar to the situation I named earlier, so we have another 55-year-old coming in your clinic. They don't have a lot of stuff going on, not on any medications right now. Now their BMI is 30. So now they fall in that stage one obesity range. Still hypertensive, LDLs are very high. But you got an ECG came back normal, no Q wave, no ischemic changes, EF, no wall motion abnormalities, normal biventricular function. And their resting heart rate is about 75. Again, this person lives a pretty sedentary lifestyle. You do a CPET and they're in that below average range. And you confirm that this person actually did their max effort by looking at that RER ratio that we talked about earlier. So you know that this result that you got is pretty accurate. So now they want to know, well, doc, what can I do to fix this? So you're going to put them on an exercise prescription. So you're going to put them on something called heart rate training, called zone 2 training, where you have them do this about 3 times a week. So right now, we always give the patient that generic response, 150 minutes of exercise a week. And most of the people, they don't know, what is that? Like, can you give me something further? And I actually have about 3 of my patients at Grady right now that I have on the zone 2 training prescription to see how can we improve their cardiovascular outcomes. And for this case here, we also gonna put them on a moderate intensity statin, gonna start them on an antihypertensive agent. And by doing this, you repeat the CPET in 6 months. Now you know that they're jumped up to 28. So even though it's not perfect, they went already up 6 points. So we know by the study that they did back in 1989 with Blair, that's a mortality benefit. So your cardiovascular risks are dropping drastically by making these changes. The person's weight can also drop down because when you talk about zone 2 training, which we'll go on the next slide, it's a lot of fat burning during this training sessions so they can lose weight in the meantime. Blood pressure is now under control, probably by a combination of them losing weight, but by also you put them on an antihypertensive agent. LDLs below 100. Their resting heart rate, which is a surrogate of your stroke volume, is now 56. So now you know that your stroke volume is working more efficiently now, pumping out more blood. And just by doing these changes, you decrease their ASCVD risk by 40%. And their cardiovascular risk is also down by like 15%. So now let's talk about practical tips of how you can help your patients. So the people come in to see you every day, and they just ask you, like, what can I do? So this zone 2 training that I was referring to, you can look at this pyramid that I created here so you can see it visually. So what we do is 220 minus our age, just like we do for everything. And what you want to target is 60 to 70% of that. And that makes you put you in the zone 2 area. So in zone 2, this is an area where it's purely aerobic endurance. So there's no anaerobic piece to this at all. And if a person stays in this zone, they do most of their training, about 80% of it, 3 times a week, it could be 20, 25 minutes, you will start to get these changes from an endurance standpoint. Your stroke volume over time will start to increase. And this correlates with people starting to have these low heart rates. Some of these Olympians come in there in the hospital with a heart rate of 40, and you want to go and try to put a pacemaker in. But in actuality, their stroke volume is just so efficient. And it's mainly because of that training that they did in this aerobic zone. Also, when you hear, I mentioned the fat burning component. So these people will start to lose most of their weight during this time as well. And you're increasing your mitochondria density. Forgot to put another picture here. So say you have 5 mitochondria in one muscle area. Now you increase that to 10. You now have more capillary flow to this area, so more blood flow going. So your muscles are more efficient at extracting out oxygen. If we look at our equation here, so if you're improving your stroke volume, your cardiac output will go up. If you're also more efficient at extracting oxygen out of your muscles, this CVO2 will go down. So therefore, your gradient here will be higher, translating to a higher VO2 max. So looking at health disparities, you always want to see your patient demographic. So my clinic is at Grady. So a lot of people don't have Apple Watches. They're not able to track their heart rate. So you can do something called a talk test method. So what this means, what I tell the patients, You could call one of your friends on the phone, and I want you to start walking outside. I want you to keep walking until you start to get, you can still have a conversation, but you're a little bit out of breath, but you're still able to maintain that pace. And that is exactly kind of translate over to a zone 2. They've studied that, even though it's kind of like the broke man's method of it, you typically will fall in that range as long as you're able to still be conversational and walk at a pace. And the reason why patients like this is actually very easy. The running in the zone 2 is for most people, so about half of the population, that's walking. Because if you tried to run, your heart rate would jump all the way up to 70 and 80%. So now you're not even training zone 2. So you want to be at a low pace. And it's frustrating for a lot of people when you start doing this type of training because you're on the sidewalk, you're running, you have on all your gear, and you want to run. But as soon as you start picking up your pace, your heart rate jumps up. So now you got to start walking. And some people get very irritated with that back and forth. But if you just stay consistent, walk for a couple of months, you're going to notice that your heart rate is now going to stay in that range. And instead of walking, you'll be able to do a light jog. 6 months in, now you're able to be a faster run, staying in that same zone 2 area, and all of these changes will start happening. So these are practical tips. And like I said, I'm doing it with my patients now of how we can use this VO2 data and improve it with an exercise prescription on top of the things we do like medically. So my last question to you is, what is your VO2 max? If you don't know it, you should figure it out and also help out your patients, and hopefully we can change lives. Thank you all. And I'm opening up questions now.
Thanks, Dolphurs. That was a really nice review of VO2 max. I learned a lot. Also checked my VO2 max. I have a little bit of work to do, so I'm going to work on that zone 2 training that you recommended. If anyone is looking for it on their Apple device, you go to the fitness app and it's under trends is where it'll show you where the VO2 max is. So I find it's very interesting that you're using it in a preventive manner. Was there a lot of data for that? I mean, I appreciate what you're doing with exercise prescription, but I wondered if you had seen that been studied before.
Yeah, I haven't seen a landmark study like we've seen the one in 1989, but in my review, yes, a lot of people have shown like tons of benefit from it, from like a weight loss perspective. Like if you go on YouTube and just go on a rant there, you see people, it's like life-changing stuff. People talk all day about it because of just that fitness level. And I just kind of pieced that together where, okay, you can lose weight, you get in better shape, and we know from the data that we do know the mortality benefit that you get from this. I kind of piece it together. I feel like it's something very helpful that'll be beneficial for most people.
You should keep track of the patients that you're doing this with and see, like your own little cohort and see what happens.
Okay. I see another question coming in.
All right. Yep.
Accurate are the watches?
Go ahead. Do you see it?
Yes. So that has been studied, the watches, and it falls in about 3 to 4% range of your actual VO2 max. So it is very accurate. But the key part is, now if you don't go on like runs or exercise for at least like 15, 20 minutes at a time, it can throw off your results. But if you've done runs at any point in time, 15, 20 minutes, played basketball, tennis, it will give you an accurate reading when you compare that to actually doing a CPET exam. I think I've seen another question here.
Yeah, there was another question from Dr. Mimo who said, how would the outcome be different if you were to recommend zone 3 versus zone 2?
So if you work on zone 3 without touching on zone 2 as much, what's going to happen, you're not going to build your aerobic threshold as well. So that going back to that pyramid that I had on my slide, so if you're only kind of hitting where your anaerobic threshold at and your base of aerobics, so your mitochondrial density, your capillaries that you're creating, if they're not there, you'll peak out. So that's why a lot of people that do a lot of running and training, they feel like my time never improves. I've been training so hard. The reason that you're not really improving is because you're still going zone 3, zone 4. If you actually do more of the zone 2 first, that should be 80% of your training, and 20% should be zone 3, because we all should still do zone 3 training, because that gives you more of that tempo. So when you're doing any type of race, you want to know how that race pace feels like. You want to kind of tap that anaerobic threshold a little bit, but your base of main of everything should be zone 2. Oh, let's see. How's the VO2 max wearable are not validated? Do you know how similar VO2 max on wearable versus CPAP. Oh yeah, so Maggie, that was the question that I explained. They have, it's not a formal one, but they have studied it because a lot of people have that question, especially people in like the running space. They're like, how accurate is this? And people actually went and paid about $200 to get a CPAP, and they come, like I said, within like 5 points of each other. So they are similar, but of course the gold standard, if you truly want to know, you should just go get a CPAP done at least once to see. Dr. Meta here. Oh, chest man. Okay, yeah, Dr. Meta kind of echoing some of the things, like in her women's clinic, with people with normal coronaries, low VO2 max. So I guess somebody echoed some of the points. Right. Any other questions?
No, I just have a comment here. I think this was an awesome topic. We don't get a lot of info on the cardiopulmonary exercise test. Um, you know, I think I was exposed to it during my congenital month, during my general training. But I definitely learned a lot more about it during my heart failure year. It is a test that I've been ordering frequently to kind of risk stratify our heart failure patients because, as you know, ejection fraction is only a number, and I think it's helpful to add the functional component. So just like you mentioned, taking that VO2 max that you get from the cardiopulmonary exercise test and applying it in the unit when these people get sicker is super helpful. And then also it can be used for heart failure with preserved ejection fraction too, to kind of tease out deconditioning with that RER that you mentioned as an excellent kind of indice to really be able to tell, is this truly cardiac disease, cardiac in origin, or do we just need to work on reconditioning? So that's another area. It goes both ways for heart failure with reduced ejection fraction, thinking about advanced therapies, and then also for teasing out true etiology with heart failure preserved ejection fraction. Awesome. This was a great talk. I learned a lot. Thanks so much.
Thank you, Dr. Brown.
Hey, this is Neil Dickert. I don't know if it's my turn or not. I had one quick question. It's a little in the weeds, but I'm curious about how much the data support this as an ASCVD risk or more sort of all-cause heart risk, mortality risk. We know the latter, right? We know low VO2 is associated with sort of bad outcomes globally, but one of the things you implied was because the patient had a low VO2. I get the reason for weight loss, exercise, blood pressure control, but you also, I think, were saying, put them on a statin. I'm curious whether we really have data to suggest that this is specific to ASCVD in a way that would warrant treatment specifically like that for atherosclerotic risk as opposed to other kinds of risk. I don't know whether that's been teased apart.
Nope, not yet. It hasn't. So right now, just more of like your clinical gestalt of putting your patients together in a whole manner, looking at all the risk factors they do have, and using this number as just like a swing point. If a person was in a place where they didn't want a statin or something, and you've seen some coronary artery disease on their CT score, like the CT score was elevated, it may push you one way or the other. So it hasn't been any data yet. Maybe it'll come in the future. Maybe I'll be the person that starts to dive into this further in the future. But now it's just mainly just a cardiovascular mortality, like stat, and they haven't put it directly to the ASCVD score. It's just more so you're doing it to kind of risk stratify your patients.
Yeah, I guess my question is whether there's a reason to believe that would be true, right? Coronary calcium is obviously is a direct visualization of atherosclerotic disease, so it makes sense that you've had a therapy that would be targeted towards that. This doesn't seem like that. So I guess I wonder whether, so I totally understand the rationale for weight loss, exercise, blood pressure control. I guess I would be a little cautious about the notion that would imply that we should specifically change our recommendations regarding atherosclerotic prevention with things like statin to some, and other agents. I think it's something that physiologically it seems potentially separate, and I'm just curious as to whether that will sort of play out.
Yeah, they are separate. So I agree with you. So I wouldn't not put anybody on a statin because of their VO2 max. Yeah, those are completely separate things. I think the guidelines still are the guidelines. I will follow that to the T. This is something that emerging, and it hasn't been studied specifically within like coronary artery disease. It's mainly just the physiology component, the cardiac output, stroke volume, your O2 levels, your muscle extraction. So we're still in that realm, and it's not attached to the coronary artery disease. So I wouldn't make any recommendations to any patient about starting to stop in a statin, anything with coronary artery disease in relation to their VO2 max.
There are no other questions. Again, Dolphurs, great job. That was really helpful with some really practical tips. So thanks again, everyone. Have a great weekend, and we will see you here next Friday.
The preceding program is copyrighted by Emory University.